Hi, this is Brad Coles out at Duke University, and I was asked to review a few files clinically using the new ARC review platform by Cadwell. And so we're going to look at a few files that were provided for review. So these are all ICU EEGs that were acquired on patients that are currently in an ICU on standard EEG monitoring using a standard 1020 montage. This is the AP bipolar montage here with a lead removed because of absent lead. And in this particular file, we see a couple of features. Clinically here, this is a fairly suppressed period prior to what looks like a seizure evolving out of this background. The rest of the background seems sort of a mix of theta and low amplitude delta, which may represent either brain injury or sedation. We don't really have any clinical information about what's going on. Here we've kind of played with this analyzer already, but we can certainly move this back up and take some of these labels off. So we can see here the rhythmic activity that begins here on the left and progresses to involve the right parasagittal chain fairly quickly. And then you see it here evolve throughout all the lead sets. This is represented quite nicely over here on these various analytic panels, and we can kind of look at how this transition period here is represented in these panels. So going back slightly here to this relatively low amplitude delta section, we can kind of go through a few of these channels here and see. This is where we are at the moment in the recording, and you can see right next to this on several of these there's going to be a peak, and so we can sort of enhance this a little bit here to better demonstrate. And there are several of these peaks around on a variety of these tools. So the spectrogram demonstrates sort of the relative power of a particular band or set of frequencies, and so gives you kind of a nice general overview. We're looking at essentially 2 hours of data across all of these panels. If we want to blow that out a little bit closer, take a closer look, you can start to see not only where there might be potential seizure activity or other artifacts. We can certainly look to see an example of that as well. Some different ways of using the spectrogram to identify or highlight key areas that you might want to take a closer look at. In clinical EEG, particularly ICU EEG, some of the critical things we need to know are, what is the background? How does that background change with stimulation? Is it reactive in sort of the new definition of reactivity, and that being responsive to stimulation? And then obviously we're doing a lot of these studies looking for seizures. So you're looking for interictal or focal abnormalities that might suggest an underlying predisposition to seizures or epilepsy. So we're looking for periodic discharges or other epileptiform discharges that might suggest this patient's at risk for seizures. And so looking at these different panels, the spectrogram often is a very nice starting point for identifying hotspots within. It's not terribly specific. Everything from artifact to seizures will give you a bump in frequency here, even EMG. So it doesn't often indicate anything of clinical significance necessarily, but it does tell you where in the file to look for changes from what's going on. So if this is sort of where you're at, we can easily click right next to that and see that this is the reason that there is a spike in our spectrogram here. Similarly, if we go back, we can find relative quiescent periods in the study very quickly over that hour, all of which look very similar, just as you'd predict from looking at the spectrogram. Spectral entropy is sort of a measure of variability, as is the alpha-delta ratio, which sort of gives you a relative distribution of alpha activity to underlying delta activity. And certainly as you get more rhythmic here, and you can often see a spike in the ADR here, depending on what the frequency of your seizures are. In this case, we have a very fast seizure frequency, This is almost 1, 2, 3, 4, 5, 6, 7, 8, 9, 10 hertz, so right smack dab in the alpha. So it makes perfect sense that we'd have a big alpha spike. If this was 2 or 3 hertz seizure discharge here, then you might see a reversal in this, and a suppression in this ratio as the delta power goes up in the frequency band. Amplitude also takes an increase here, as you can see, compared to our background, which is fairly suppressed. The amplitudes get larger over time, and that's reflected in this increase. So you can pretty much jump right to the same area of the seizures within a couple of pages here, just by picking out the bumps in amplitude here, which clearly identified. And then there's an asymmetry here if this seizure was occurring preferentially on one side or the other. It looks like if we follow this out, there may be a little bit of a preference on the left. We noted it started on the left, parasagittal chain, and so there may be a little bit of an asymmetry here represented as a result of the higher amplitudes, which will affect the envelope asymmetry calculation a little bit more. These amplitudes are much larger on the left than the right, which gives you an asymmetry here. So all these kind of make intuitive sense and are somewhat useful in at least identifying these events as the need for events that should be taken a closer look at. I don't know that there's any. This is a little bit different. You can see it's a lower amplitude, so we can see if it's still a seizure or if it's something else. Nope, still a seizure. So there doesn't appear to be a lot of other movement artifacts. We can blow this out here to 8 hours and sort of look across the whole study and see. Here we have a little different background. There's a little bit more activity. It's less suppressed. Still having seizures here. Trying to see if there was any kind of nursing interaction to kind of get a look at reactivity. You can also notice there's not a lot of EMG with these seizures. So as you look at the seizures go by here, this is probably noise on this channel, but there isn't really, for a left-sided seizure, you don't see EMG on the right. That would suggest maybe a facial twitch or something else. This is probably a fairly subtle or non-convulsive, non-clinical event. We don't have video here to sort of demonstrate that, but that would be my expectation given the absence of EMG artifact with those discharges, which can sometimes help. If you get EMG, at least it gives you a signal here if your analytics here are not picking up the seizures particularly well. So, but these seizures are fairly well represented in here, and I don't really see a lot of other activities for us to go chase here. There's a little bit of an artifact. I was trying to see if we had, oh, there we go. So again, this is the non-specificity of these tools in some cases. So this looks like probably some kind of movement artifact. Either the patient's being rolled around, or oftentimes when suctioning or some kind of vent management is done, you'll get these movement artifacts. And so those will produce the same sorts of spikes and peaks in these spectrograms that the seizures did. It also produces sort of arbitrary, this is sort of a mixed bag of frequencies. So it's unpredictable how a movement artifact will affect your various calculations just based on what comes through, whether it produces noise in the electrodes with 60 hertz or whether it just produces these low frequency oscillations as a result of the movement. But they do, again, it does help you isolate areas where the patient's been maybe manipulated or stimulated. So you can assess the background change here after stimulation to that beforehand to determine whether or not the patient's reactive to stimulation, which can be an interesting or helpful prognostic factor in terms of some clinical states such as cardiac arrest, for example. So why don't we look at another file here? We'll see this one was certainly pretty well represented on the quantitative tools here. We'll open another record that I know has some seizures in it, and we'll see how those look. So this patient has a mix of interesting features here. So we have EMG that's throughout, a little bit more prominent on the right here than on the left, but basically present in both sides. And so we can kind of look over here, and what's interesting is this doesn't look quite as pretty as the other one, but then you have to look down here and see this is pretty much the entire file compressed across here. So if we want to get a comparable view, we should drop this into the 2-hour window here, and then that would be similar to what we saw before. So again, if we go down to the spectrograms to try to kind of get an idea here, I added a band power trend analyzer, and you'll see why I did that in a minute. So here we have this period where this looks like chewing artifact. So this is probably somebody who's awake enough to eat. So again, it tells you how this is really a non-specific way of looking at the EEG, but it does hone in on a significant change from background. If we go back out here, we can kind of get a feel for the background. So this is obviously an awake patient who's capable of eating. So it's a little bit hard to see in ODR, but there's clearly one there. It's kind of a low voltage fast background with a little frontal rhythmic activity, but nothing jumping out at us as epileptiform. And so this is a chewing artifact. You can see there's no real change in the background between those discharges, and that they're all EMGs there. So that's how you identify those. So let's look at a couple other spots here. Here's another point and another point. So these are all mealtime. But what you can see here, this is sort of, we looked at a power band, and this is looking at a fairly narrow window here. So we picked I picked this right frontal region to isolate, and looked at just the frequencies between 5 and 15 hertz. And so that's kind of how that's set up. And so it's very similar to the spectrogram, but I'm just looking at one band. And we see this big dip here in power in that region. So if we go there, we can kind of see what happened to the background here. So it looks like some eye blinks, some other artifact in there. So the background does look a little bit different here, less EMG, maybe a little slower, a little more suppressed. Not totally clear why. Here's the EMG coming back, so that throws off our band power. So let's go up here and we'll look a little bit further down the road here. See if we can find EMG. So here's the seizure that we knew was in this file here. And what's I think kind of interesting about this is, unlike the last file, these are a little harder to spot over here. So we're at the far edge of our window here. So let's see if we can move this over a little bit here, and we'll go back to our page. But the seizures don't really stand out like this. Like this is kind of how the ones from the previous file looked. Whereas here, you would not necessarily think that there was anything happening here. And so this is kind of a common problem for this approach to EEG review, and it's why we all kind of have a little bit of hesitancy. So this is where the bandpass analyzer comes into play here. So in looking at these seizures, I've custom generated a trend down here where I know that occurs in this particular region, because after the seizure, there's significant suppression. And so I'm able to more easily pick up these periods where this seizure occurs, and then after the seizure, you get this transition to a different background. And so by using that approach, I'm better able to find these where these other tools kind of let me down. And it gives you a nice high amplitude signal that's pretty straightforward. But you could use entropy. I think that was where I wanted to try to look at spectral entropy. You would expect that to actually be lower because you have a very rhythmic output. So again, you can quickly build this out using the same sort of lead pairs that we had before, just using this right frontal region. That way you don't average out the signal here, by including a bunch of leads that may be less affected, or if they're out of phase, as you start to mathematically bring this together, then you lose your amplitude change in your signal. So we can just look and see what this looks like de novo by restricting our calculations here, or we can even drop this down further out of this frequency range. But let's start with this and just see what we get here, and see if that helps us any farther. We're gonna have to wait for that to calculate for a minute here, but it shouldn't take too long. And we'll see what you'd expect is there to be a drop in entropy, and you can definitely see that here, where the entropy drops off as the seizure evolves. More so there than in the current spot, although I might be right on top of the drop here. So if we go back to this one, just as an example, you know, it's not as dramatic as you'd like. So you could go and play with some of these settings here and see if you minimize this down to 25. Probably have to change these windows here, and then let it recalculate it, see if we can hone in on this frequency here. But that's sort of the idea as well, that you can custom pull out regions of interest and scope these down, because these are more or less like hemispheres that are being averaged and brought together. So probably need a little bit higher frequency content, but again, you can kind of see the reduction in entropy with the seizure as it comes through, and then you end up with this flat suppressed period later. So it gives you an alternative strategy for putting these things together to find these events. Let's go ahead and try this strategy of blowing this out to 4 hours, so we can find another seizure right there. Should be right back here. See if we can find it. There it is, as predicted. So again, the tool works very well once you kind of come up with a strategy for finding those using one of the available tools. So that's just an example of pulling that out in a situation where you, like the last seizures were so nice and so obvious, you didn't need to do anything. You could read it on every panel. This one you had to be a little bit more creative with. So that's that one. So this is kind of a neat file. So you know, just looking at it here, there's some EMG. You got eye blinks in here, and so this is probably an awake patient who's kind of hanging out here. You wouldn't expect him to be on a lot of sedation, and there's a suppressed background because their eyes are open. So that's sort of the classic definition of reactivity, lower amplitudes, and the alpha ODR as a result of open eyes. So over here, we kind of don't have a lot of signal over here, but we are, again, across the entire file. So to get a better look at smaller segments, it's better to move to a different time base. And so let's see, I'm going to maybe do 4 hours here. So here, there's sort of this envelope calculation here across the entire montage. Kind of gives you like an interesting look here. So there's this relative low period in here and this higher activity period. So as you click in here, you see, oh, this person's eating. So our prediction of them being awake and functional is confirmed. And here again, so this is sort of a very active period. And so then when you go out here, you can see quite different background. This has less EMG. It's still relatively fast, but not terribly so. There's a little bit more background here in amplitude. So with the video, you might be able to confirm their eyes are closed. Now we see maybe a sharp here. That's generalized. There's another one there with the reversal. So maybe some epileptiform activity. And so this represents a different state from the awake state to maybe a resting state or a quiet state. And so this is also very helpful as you go through ICU EEG. This is probably an EMU or another, you know, an ICU patient, maybe a post-operative patient who's awake and eating, but you're worried about episodic events. You can kind of go through and look for things like sleep architecture, which often can help point to abnormalities if there's an asymmetry. where the sleep architecture is better on one side than the other. So again, these these trends can be very helpful in sort of getting the high-level overview of the overall change in functionality in brain over time, just by looking at sort of these broad states and then quickly reviewing the differences between these different areas in here. And so I thought this was a good file for that. So this patient, as we noted here, is awake, has a really great background. There's definitely an asymmetry here. So, you know, this is probably not, this is left over right, which is okay, but sometimes it's helpful to put the two parasagittal chains next to each other and the two temporal chains together, as opposed to putting the whole hemisphere on the left over the whole hemisphere on the right, because it helps do a direct comparison for slowing in that. So here you really want to compare this top set of leads to this set of leads. This is the two parasagittal chains in the AP bipolar, and here we can see that it looks higher amplitude and maybe even faster here on first glance, but you're sort of obscured by EMG a little bit here on the left. So you're not totally clear how fast and what the true amplitude is on the left. Certainly frontally, you get a little bit clearer picture that there's probably at least alpha or maybe fast theta over there. And so this, you start to wonder whether this is maybe a breach over here, maybe a craniotomy site. And then when you look, we can kind of crank up some amplitude here and get a better look at some of this. Here, this is too high an amplitude to read, but we know there's some higher frequency there, and it looks pretty good over here as well. So temporally, not too bad. So you're trying to figure out if there's something focal going on here. And so, as we mentioned before, one of the things that sometimes is helpful is to look for sleep in the file, and then look at sleep architecture as an indicator of function. And so if we kind of scroll through, here we see we can use this, any of these really, most of them are showing this change. So there's clearly a state change as you go from here, where this patient is awake and interactive, to another state here where you have slowing and background fragmentation. So unless we've instituted sedation, maybe intubated the patient or done something, then we could check the video and see if they look clinically asleep, then this likely represents a sleep state. And then you can page through and look for formal sleep architecture. And unfortunately, the saying in the unit is nobody sleeps, not even the providers. But here we do see maybe a little bit of K complex with some spindles afterward, and we can kind of pull that out into the thing. And look, it's not great, and it's not super well formed, but then you can kind of do a side-by-side comparison here and say, yeah, this is higher amplitude, higher frequency content. You know, it's reasonably well, similarly formed on both sides. Maybe there's a little bit better representation on that right side, but it's really pretty well seen on both sides. So this is probably a breach artifact as opposed to you know, something else, a lesion on the left or something like that. It's entirely possible that the amplitude asymmetry is due to something like subdural or soft tissue swelling over on the left, and that's why the left side is lower. And so generally, if it's greater than 50% difference from one side to the other, then you would report that out. And of course, we would go and look at the CT scan and the clinical history to determine whether they've had craniotomy or a burr hole drainage here, to determine whether or not this T4 might be sitting over a burr hole or something and giving us a breach rhythm there at T4. The rest of the study looks pretty symmetric. And again, this was a good example of finding sleep architecture and sort of validating normal brain physiology and really pretty symmetric functionality on both sides here, with the corresponding changes across all of these different metrics for the different states. So again, you can kind of see the overall higher envelope frequencies here. If we can blow this up a little bit, you can see the higher activity levels here in this portion of the study versus when we go out here and this patient falls asleep. They get some background fragmentation slowing here that's well represented across all of these various channels. And we can page through here and look and see when the patient wakes up or is examined or bothered, and look for other things too. We'll see if any of these spikes have any interesting information in them. Looks like the person wakes up here a little bit, which is what you'd expect here from the change in the backgrounds. So not much there. Let's see what else. Page through here. Here's a spike in activity. Doesn't really have a particularly strong correlate. Some EMG maybe. Let's see if we find any of these. This is an interesting amplitude transition here. So you go from this right here. So this is amplitude integrated EEG, which is really helpful in pediatrics. It's been well studied there. Less so in adults, although occasionally, like we saw in the last case, or the first case rather, it does work for picking up seizures on occasion. So here it's probably picking up some of these eye blink artifacts that we're getting anteriorly, and it's giving you this big bump in amplitude right there. So that's not anything. So we'll look at this one. This is pretty neat. This is a neat file. So things that look like this. So these are look like generalized periodic discharges in here. So they're on both sides throughout the file. They're periodic. The intervening EEG is relatively suppressed. You get a little bit of activity between some of these, and so this is a very common pattern seen in cardiac arrest. So it wouldn't surprise me if this was a cardiac arrest patient. There are other clinical scenarios where this has been seen, but that's probably the most common in terms of ICU monitoring. These often will sort of be looked at carefully for their complexity. So if you have lots of phase reversals and complexity with these, that tends to be more concerning for something that's going to evolve into seizures. Those that are wider based, more sort of less sharp in appearance and less frequent. So frequency is another big component. Like this is fairly infrequent. It comes in runs and clusters, but it's generally low frequency. Those tend to be a little more benign and less likely to transform into status or seizures, gross electrographic seizures. This patient's already showing some increased activity between these, and the natural history for these, if you look at a lot of EEG, is that often these amplitudes just diminish over time and they melt down into a background that becomes continuous over time. So looking at some of the prognostic aspects of EEG, it turns out that the EEG carries more prognosis power early in the first 24 hours to maybe 36 hours. Looking at this, we have sort of these intermittent periods. We're kind of waiting for this to build out. Here we can again change it from being the entire file down to maybe a 2-hour block here. And so here we have sort of some interesting transitions. Again, you can kind of use your first pass here to kind of look at changes, gross changes in total activity from one period to the next. So here we have a fairly decent shift in amplitudes that occurs, and that's sustained. So whatever that change is going to be a change that's sustained over time. Looks like we also have a change in our envelope asymmetry. So it's relatively symmetric. There isn't anything in particular, and it's more central and equal. So there's a little shift away. So I think you're probably looking at some EMG artifact that comes in here, is what I would guess. And again, we're looking at this just in terms of trying to find a good chance to review. Here on the left, we see that there's significantly more sort of higher frequency noise than on the right. So you might expect, if you click into this, that you're going to see probably a lot of EMG on the left, or something's going on the left that's not going on the right here. And we'll look at that and see, and there's a bad lead over there on the left. So it's probably your artifact that's playing into here, while the rest of the EEG is relatively suppressed. So on the right, it gives you a much clearer picture. But again, this is the sort of the limitation or the drawback of the spectrogram as a single isolated panel. So it's very nice that there are several different measures here that we can go with. So this amplitude may be also being affected by this artifact here in how it's calculated. So we can kind of skip through here and G5. I think that's the main one. Now it's going to recalculate that though, isn't it? There we go. Let's see what it does for amplitude. Yeah, so that corrects that trend pretty nicely. So we had that big shift up before, and now we can see that there's a better representation there. We could probably do that with the spectrogram, just as another dramatic example. So we think this is a lot of noise. So we can go in and take T5 out by highlighting that, and just remove that from the calculations on that side, and then let that recalculate. And we'll see if it looks more like the right side. So that cleans up very nicely. And we can blow this out a little bit. Show that's pretty similar. I can set these the same. All right. So that's nice. That allows us to get some of the noise out by just changing the settings a little bit on the fly. Let's see if there's any. We'll just kind of page through here and see if there's anything exciting that jumps out. We can see though that the generalized activity is already a little bit lower amplitude even partway through this study here, which makes me want to look at the end of the study. Let's see if we jump to the end here. Crank our way out here. We may lose more leads, but that's almost as far as I can get there. All right, so we got some action here at the end. So what's neat is this patient has EMG that recovers, and so that's sometimes a good sign and it suggests that they're responding to stimuli, although I think the jury's out on whether you can count that in cardiac arrest or not. But it does indicate at least some kind of response to their clinical situation. And kind of as we expected, since we could already see changes early in the study, again, we got a kind of a bum T5 electrode here. But if we just focus on these top traces, you can see the GPEDs are not even well represented all the way through this parasagittal chain anymore. They've sort of moved up to a mostly frontal position. They're a little better represented on the left still here, although it's a little challenging to see. But again, our amplitudes here are waning on the GPEDs. So this is kind of the natural history for these over the first 24 to 48 hours in patients who are at high risk. And I think those that often have worse outcomes, these are relentless and they will persist for greater than 24 hours instead of resolving like this. And often will be at a higher frequency, so 1 to 2 hertz, and be much more threatening than this particular patient's discharges are. And over time, this may even become lateralized discharges over on the left, since that looks like they're still better represented on the left than the right towards the end of the study. So that's some ways that you can integrate both of these, this sort of overall quantitative panel with a real-time review and read as you're looking for these clinically significant findings within these traces. I think it is, it is kind of one of these things where you just have to do it, and then you just start to learn on the job. It's hard to prep yourself too much. You have to just kind of read the files the way you normally do, and then look at the trends that correspond to things that you think are important. And so, you know, I think over time you just build your repertoire just through experience and time.